Hi, my name is Connie from Finance and you're watching a video on the Prism Subjective. Now, we've just discussed a variety of tests that we can utilise to assess binocular single vision. So we looked at the 20 diopter, where we can induce a mode of fusion response to detect the presence of BSV. We've talked about looking at the strength of the patient's binocular functions by measuring the fusion range. And we've talked about measuring a patient's stereo acuity. Now, these type of tests, in order to perform them, when we commence the test, the patient must be straight or bifoveal. With the exception of the microtrope who has subnormal binocular functions, all other types of manifest strabismus patients cannot perform these tests. So, for example, if I have a patient who has a 50 diopter right ET and is experiencing diplopia, when I introduce a base out prism, I'm not going to see a fusional convergence movement because the image is already on CIP and I'm just going to be shifting the image towards the fovea. I need the patient to be fovea to fovea or fovea to pseudofovea, which is the case in, or is often the case in the microtrope, so that I can then assess the patient's binocular functions. Same goes for stereo acuity. If the patient isn't fovea to fovea or fovea to pseudofovea, when you present that stereo acuity card, they will fail it. They'll fail it if they have strabismus that's leading to diplopia, and they'll fail it if they've got strabismus that has suppression. Okay, so now let's think about the scenario of a patient who's 20 years old, who has a recent onset strabismus and has a 50 diopter right esotropia. So given that this case suggests that there's no previous history of strabismus, I would suspect that this individual would have binocular functions. But in the clinic, whilst they're sitting in my room in free space, I can't assess their fusion range. I can't assess whether they have BSV. And so how do we determine if this patient is likely post-operatively, if we were to operate on this strabismus, is going to achieve BSV? We need a mechanism to find out what is the strength of this patient's binocular functions, even though right now in free space you have a strabismus. Or do you have the potential for stereopsis and fusion post-operatively? And the Prism Subjective is one of those tests that will allow us to determine if a patient can be binocular or has the potential for BSV. So the patients we're generally performing these tests on are patients with a constant deviation, where we need to neutralise the deviation and then determine if the patient has binocular functions. And what I mean by neutralise is that we bring the patient fovea to fovea. So we neutralise that deviation in order to then work out what is their response at that point. When they're fovea to fovea, do they have binocular functions or not? I just want to make a point around intermittent deviations. Intermittent deviations, you can do a prism fusion range and you can look at stereo acuity with these patients whilst they're controlled. So if you commence the prism fusion range at a time when the eyes are straight, then you'll be fine. You'll be able to measure the strength of the binocular functions there. But should you commence with a point in time when they're exotropic, for instance, you can't continue. So these patients are a bit trickier to measure their binocular functions. You may need to neutralise or you may not need to neutralise. The other thing to note about intermittent deviations is generally, as compared to a constant, we know that these patients should have binocular functions. If we take an intermittent exo as an example, generally what this means is that they at times have an exophoria, which means this is the time that they have binocular functions, versus times when they have an exotropia. So we already know that these patients are or do have binocular functions because they go through between states of control where they've got binocular functions versus no control where they are manifest. So it's the cohort of patients with that constant deviation that we're really not sure whether they have binocular functions, and we need to go exploring whether the patient has the potential for it. Okay, so in the Prism Subjective, how do we go about neutralising the deviation? Well, clearly we're going to use prisms, and we're going to shift that image from CIP to fovea. As we can see in the example here to the right, the patient has a left esotropia, fixing with the right eye, and CIP is on nasal retina. We put a base out prism, shift the image to the fovea, and now we have a starting point like we do in patients who are bifoveal, where the patient is fovea to fovea. And once neutralised, we can present, for instance, a test that determines whether the patient does have binocular functions. So if with the Bagulini striated glasses, with the neutralised angle of deviation, they have a cross, then what we know here is the patient has a normal retinal correspondence. If we have one line, then we know that they have suppression at fovea. You could even assess stereoacuity and see whether that patient has stereopsis once you've brought them fovea to fovea. So how do we determine what prism to put before the eye? Well, we already know that objectively we can determine where the fovea is by performing a PCT. And this angle of the size of the deviation is telling us that's the prism we need to put the image back on fovea. So if we did a prism cover test, it was 25 diopters base out, then when we put that prism in front of the eye, the image should fall on fovea. And in doing this, we can then present the Bagulini striated glasses and ask them what they see and determine whether the patient has normal retinal correspondence and whether they have simultaneous perception and sensory fusion. Okay, there is one other way, subjectively, and this is particularly required if you're thinking of prescribing prisms for your patients by using the Prism Subjective. Now, if you're simply wanting to bring them fovea to fovea and look and see whether they've got sensory fusion and simultaneous perception, then you might get away with just objectively. But if you're going to prescribe it, you want to do this subjectively, which requires your patient to respond to you. Now, what we do here is we allow the patient to tell us when they see one. So in this example here of the patient with a 25 diopter base out, what we would do is introduce the prism bar in front of the left eye, base out, and continue increasing the strength and ask the patient to tell us when they first see one image. Now, when a patient says they see one, there's one of two things happening. Either you've moved into a suppression scotoma or the patient now has BSV. And the only way you'll know that is, again, introduce a test like Bagulini striated glasses and determine if they have one line or they've got the two lines and the one line. Now, the advantage of doing it subjectively is that when we prescribe prisms for the purposes of giving patients binocular single vision, what we want is to give the patient the least amount of prism that gives them comfortable BSV. And so subjectively what we want to know from the patient is when do you see one and what's most comfortable. Now we can see here the actual method that I've just discussed, and the clinician holding the prism bars whilst the patient is fixing at a target. Now you can do this at near and far, and what we can see in this photo, if you look carefully, is that these are stacked prisms where the patient has both a vertical and a horizontal prism in front of their eye, which means this patient has a vertical deviation and a horizontal deviation. So the clinician needs to neutralise both the vertical and the horizontal in order to work out or determine the prism where the patient first achieves comfortable binocular single vision. In terms of the Prism Subjective, you'll have to indicate the prism that gives the patient single vision and some proof of the single vision, that it is actually BSV when you neutralised the deviation. So here's an example. We have Prism Subjective. It was performed in the distance, and we've got the patient has BSV with 25 diopters. base out, and we've been told the test that the patient achieved or showed binocular functions, which is the Bagolini striated glasses test. Here we have the same. This time it was performed at near, and the patient had single, so one image with 25 diopters base out, and then when the Lang was performed with this 25 diopter base out prism, they noted 200 seconds of arc, so we now have proof that there is BSV at that distance. Now, before we conclude, it's worth mentioning one more thing. The Prism Subjective, or any test that seeks to find out the potential a patient has for BSV, can be used for numerous reasons. One, we've talked about as a pre-op assessment to see what potentially could be the post-op outcome. Can we expect the patient to have BSV post-operatively? Is that a prognosis for the patient? Secondly, with the Prism Subjective in particular, we can utilise this as a form of treatment. We can try and give a patient BSV, particularly if they have diplopia and they come to your clinic with a complaint of diplopia. We can use prisms to give patients binocular single vision. And the way we would find out what prism to prescribe would be by the utilisation of the Prism Subjective. And finally, by performing a Prism Subjective or any test that tells us about the potential for binocular functions, gives us information about the history of this patient's strabismus. So if we go back to that earlier example of where I said a 20-year-old comes to your clinic and presents with a sudden onset esotropia, if you found that the patient had the potential for BSV, then it supports that this is new and it supports the presentation of a sudden onset. However, should you have attempted to look for the potential of binocular functions in that patient and you could not find binocular functions and you found suppression instead, yes, maybe there has been a sudden onset esotropia, but there has to be something old underlying because there's a sensory adaptation present. And the only time that suppression develops is when you're younger. So again, assessing a patient's potential for binocular functions can give us three types of information. One, prognosis for post-op outcome. Two, can give us a treatment option for our patients. And three, it can give us information about whether there may have been a history of strabismus. Okay, that brings us to the conclusion of this video. Thank you for watching.